Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insights into all things medicine for junior doctors and medical students in South Africa. Welcome to episode 22. And on this week's episode of the podcast, I interviewed Dr. Nishlin Naidoo, a consultant in the Department of Surgery at Maxeke, Johannesburg Academic Hospital, and a fellow in colorectal surgery at Wits University. Dr. Naidoo gave me a fantastic insight into his journey in medicine and his decision to become a surgeon, as well as the algorithm that took him down the path to becoming a colorectal surgeon, with all of the nuances and subtleties about that specific subspec. I think this is a great episode for anyone interested in surgery and the various subspecs within surgery, or a student going into surgery rotations in their clinical years, and junior doctors working in surgery maybe during internship or medical officer time. I thoroughly enjoyed our conversation, and I'm sure you will as well. So without any further ado, here's my interview with Dr. Nishlin Naidoo. Welcome to the Dr. Coffee Podcast, Dr. Nishlin Naidoo.
Thank you, Simon, for having me on your podcast. It's a real honor to be here.
Thank you for accepting the invitation, and we're excited to find out all about colorectal surgery. And before we dive into your speciality, let me ask you the question we ask all of our invited guests. Where did you do your medical school training, and where did you do your junior doctor years, so your internship and ComServe, things like that?
I did my medical school training quite some time ago. So it was in UKZN, Nelson Mandela School of Medicine.
Mm-hmm.
And
was it called that?
Yeah, so I think it's still called Nelson Mandela School of Medicine, if I can recall properly. I finished in around 2011, and it was obviously on a 5-year program.
Oh, okay.
And we then changed to a 6-year program during the course of my time.
So did they tell you while you were doing your 5 years, oh, by the way, you have to do an extra year, or did you complete a 5-year?
So I completed the 5-year, but there was obviously a gap in my 4th year where they decided to go back into the 6-year program.
Mm-hmm.
So the new lot of medical students coming in as first years would obviously revert back to the old 6-year program. Yeah, so I dodged a bit of a bullet. So it was great, but obviously now that entire syllabus was not crammed, it was spread out appropriately. Sure. I feel over a 6-year period, that enabled people to obviously learn a lot better and do their basic sciences a little bit better as well. Okay. We obviously didn't have a GEMP program in KZN, and that's something that's been established at WITS, which is obviously fantastic because, I mean, you're a GEMP yourself.
I benefited from it.
Yes, exactly. I finished in 2011. I then went on to do my internship at Mahatma Gandhi and Addington Hospital. Okay. And that was a 2-year period.
And are those two hospitals linked? Like you do some rotations at different hospitals?
Yes, correct. So I did surgery at Addington. That was lovely. It was on the beach. Anesthesia and orthopedics.
Surgery on the beach.
Yeah. Well, it's the way I thought about it. But, the hospital's on the beach. So, after work was pretty cool because you could go out to the beach.
Amazing.
And this was just after the World Cup. So everything was developed down at the Durban beachfront. So that was fantastic, just doing that block there. The rest of the time was spent with pediatrics, internal medicine, and family medicine, obviously done at Mahatma Gandhi Hospital.
Is the setup similar to the way that Helen Joseph and Rahima Musa are the same hospital complex, but different rotations are done?
100% correct. Yes, it's exactly like that.
Okay.
So it was good because you got that exposure to learn from two different institutions. Because obviously, no matter where you go, as much as hospitals you think are the same, they actually are quite different.
Okay. Which one was better for you? Which one did you enjoy more?
Probably Addington.
Okay, because of surgery?
Well, not really surgery. I just liked the vibe of the hospital. It was really cool. I love my internship years. Yeah. I really look forward to it. It's something I think about quite a lot. Medical school is just a bit of a blur. But
your memory only starts at day one of internship.
Correct, yeah, because that's when you're thrown into the deep end and you start working, obviously. And going from studying to working is a big change for most people. Lots of people struggle with it.
Did you feel well prepared for internship? Do you feel like your med school was adequate training?
No.
And aside from the 5 years versus 6 years thing, were you competent? You were confident in what you were doing?
No, not at all. And and there's nothing wrong with that. And I think interns need to understand that you're going to go into a new environment, you don't know what to expect, and it's okay to not be confident. Sure. That confidence comes with experience and managing patients and watching and observing how other seniors manage patients
Sure.
and learning more. So yeah, I was quite anxious going into internship.
Oh wow, really?
And yeah, you slowly develop as you go on in your career. So it's nothing to be disheartened by, if you are a bit anxious about internship.
Yeah.
So
I think especially for those who have just graduated and have maybe been placed at an unfamiliar surrounding, like let's say you are a Wits graduate and you've been placed in another province,
Yes.
so you're now going to a hospital complex where you don't know where anything is. Added on top of that, the gaps, the chapters you didn't read or the cases you didn't get to see. It can be quite unnerving. So it's comforting to know that no one expects you to know everything, as an intern. And then after internship, you said you did ComServe?
in Kimberley Hospital.
Okay.
So yeah, during my internship, actually during medical school, I decided, surgery is probably something up my alley. I just needed to do something with my hands.
Mm-hmm.
I just didn't know what. The dream was always plastics.
Oh, wow.
But that slowly faded away over time. And I think I wanted to try a little bit of whatever I could.
Had you rotated through plastic surgery before?
No.
So what was the allure of plastic surgery?
Dr. 90210.
Okay.
So yeah, cosmetic.
Yeah,
stuff.
you wanted to. Like,
I wanted
fix
to
up
be that
people's
guy.
lips and-
I wanted to be that guy and do some complex
Noses
flaps
and-
and things. But
No, because in our setting, plastic surgery is very much like tied in with trauma and burns, and not just people who want a boob lift.
Yeah, exactly. So the cosmetic part of it was something I was always interested in. Cosmetic dermatology was also something I was interested in as a student. But obviously, you don't get that sort of exposure during your internship years.
Sure.
You get a very short period of time spent in dermatology. I'm sure even with you and the current rotations that you guys have.
So interestingly, for us at Charlotte, there was no rotation as an intern through dermatology. So all of our training in derm was as a student, and even then, like you say, it was minimal.
Yeah, but things change.
Yeah.
So that's the interesting part about your career in medicine is that you'll find something that you just like, and it can come out of nowhere, which is what happened with surgery.
Yeah.
So I chose Kimberley because I thought it would give me variety. The reason I say that is because it's a tertiary institution, and it obviously the Northern Cape is the largest province in the country.
Yeah.
With the smallest population.
Oh wow.
So it's a good place to learn from. There are no registrars there. It's essentially run by consultants, registrars. Medical officers and community service doctors.
Wow.
And interns. So it's a really good place to learn, to get exposure and experience before
Why no registrars? Is that because there's no medical school affiliated?
The medical school affiliated with them is essentially in Bloemfontein.
Oh, wow.
Previously,
it's a bit of a drive from Bloem to Kimberley.
It's about 150 Ks, if I remember correctly.
Sure.
I'm not sure if things have changed, but when I was there, they weren't really rotating registrars readily through surgery.
Sure.
And, they had their own reg set up in Bloem at Universitas and so forth in Pelenomi. But for the most part, I enjoyed that time in Kimberley. I did 6 months of neurosurgery.
Wow.
And then I tried my hand at it. Look, I have a lot of respect for neurosurgeons. It just wasn't my cup of tea. And then I did general surgery and loved it. So, I stayed on for another year after that in Kimberley as a medical officer. Okay,
so you chose Kimberley. Had you heard any good reports about it? Had anyone influenced your decision to go to Kimberley?
Yes.
Okay.
So I did quite a bit of research, and I spoke to guys that were from there. In fact, in my first year of internship, I actually got in contact with some of the HODs at Kimberley and, emailed them and said, I have every intention of coming to this hospital.
Oh, wow.
And I didn't realize that at that point, not many people wanted to go there.
Okay.
So, applying to go to Kimberley wasn't a problem. And, being out in sort of a peripheral institution, and it actually isn't. It's central.
Yeah.
It made it was a real advantage, I felt.
When you say it's central, it's like literally central because it's equidistant from Joburg and Cape Town.
Yeah, exactly.
It's the same distance to everything in South Africa.
Yeah,
it's just far.
it's just in the middle of nowhere.
And what was the change like going from Addington, where you said like inverted commas surgery on the beach, to now you're in the dry Karoo, far away from everything else?
Yeah, so look, I grew up in Durban, and this was the first time I'd left home.
Yeah.
So, and during internship, I stayed at home as well. So it was different. It was a change for me.
Yeah.
But I loved it. A lot of my classmates or guys that were in med school with me joined me in Kimberley. So It was great. And, some of them are currently working with me here in surgery, and they're fellows in some other subspecs in surgery. So one's in vascular surgery, one's in an HPB fellow at the moment. So, and I stayed with the two of them, in Kimberley together, and we did our ComServe together, and we were all working back here. We found ourselves back in the same place. So
that's amazing.
That network sort of stays, and it's pretty cool.
Yeah.
So it's nice having people around and coming up to Johannesburg. So it awesome. Was fantastic. Yeah.
So the surgery bug bit, and that's a bit fairly early for you. It sounds like during internship you were like, right, surgery, you were starting to make some preparations for the future path. So at what point did you then say, okay, I've got enough time to write my primaries? Was it after that second year? Like that second year sounds like it was ready to lay a foundation.
Yes.
So when did you say, right, I'm ready, I want to do a registrar?
It was during my MO time.
Okay.
So I think I spent 6 months in surgery at Kimberley, and this was the last 6 months of the year. I think one of the more nerve-wracking things for me at that point was, where am I going to get a job? And so I applied to a lot of places, and I applied to Kimberley and got that post in Kimberley. And I stayed on for another year just to gain a bit of confidence. Surgery, a lot of surgery has to do with both operating and managing patients, and sick and critically ill patients. And I just felt I needed a bit more confidence, especially in theatre with basic stuff. So during that time, I wrote my primaries, and it's good being in a surgical environment when you're writing primaries, because a lot of the pathology that's asked in the exam comes out in that exam.
Okay.
So as much as you can read and pass an exam, just having that practical exposure and experience enables you to answer that multiple choice question.
And being in a hospital that was largely consultants and MOs with no registrars, I imagine that you got that theatre time.
Yes.
You got to do a lot of work with your hands and develop your skills practically.
Yes, of course. Awesome. And the fantastic thing about it was that the consultants that worked in Kimberley Hospital, 2 were trained at Cape Town.
Okay.
And 1 was trained at Wits, and the other was a Cuban surgeon. Very experienced guys, and I learned a lot from them. Even up to today, I still practice some of the things that I learned as a medical officer, and I had safe outcomes with my patients doing it the way that I was taught initially.
Sure.
So it's not that I was learning bad habits, and a lot of people have that stigma, or that, not really that stigma, but that the thought that if you're going to a peripheral hospital, you may not necessarily learn the right thing. But it's not always the case, especially if you've got good supervision.
Yeah.
So I think Kimberley is one of those fantastic hospitals to be in, because no matter what field you want to go in, whether it's pediatrics, medicine, radiology, they generally have a good bunch of consultants and young consultants that constantly rotate through.
That's awesome.
So I would advise people, if they're looking at surgery, it's a good place to consider applying. Yeah,
and for the viewers and the listeners taking notes, they're now writing down Kimberley as one of their options for internship and community service.
Yeah, it's also a vibe. So it's pretty cool when you're there, like you meet up with a lot of friends and you have a lot of fun afterwards.
I wouldn't immediately associate Kimberley with anything other than the big hole.
Funny enough, I didn't even go there.
Oh, wow. In 2 years.
I was there for 2 years, but I didn't go. I didn't even see the big hole. But I made a lot of friends.
Okay.
And some are actually not even in surgery. This is one that's in a neurosurgery consultant now.
Sure.
The one that's in anesthesia, 2 or 3 that are in anesthesia. So
Amazing.
It's great to see that the people that were with me as a medical officer and in my ComServe year are here doing their time as registrars and now have finished as consultants.
Awesome.
So it's cool. Yeah.
So we've heard from previous guests about the journey through general surgery, which basically involves having at least written your primaries beforehand, and everyone advises doing your courses, your ATLS, your basic surgical skills, things like that before you start your reg time. And then after you've done your 2 years of junior reg time, you reapply for your senior reg post. At least that's how it works on the VIT circuit, where having that senior reg post involves, your MMed, and you've at least written your primaries and things like that. At what point in your general surgery training did you start to decide that colorectal surgery was where you would want to go?
So I think the first part for me, once I made that decision to do general surgery, was obviously to apply for a reg post.
Okay.
So I applied everywhere.
Yeah.
I had written primaries and thought that, hey, you know what, I've got a whole lot of cases on my logbook. Great. I've got my primaries. Great. I've got this long-standing experience. I've got over a year now of experience and my ComServe time, and I did some neurosurg time. great, I've done some courses, ATLS and so forth. Let me apply for my surgical, reg time.
Yeah.
And initially I had this thought that, and people would always say, you need intermediates, try and get some ICU time. And I also want to make it clear that it's not the focus now. As much as primaries are a requirement, the most important thing is having some research component to apply for a general surgery post. So it's something that is held in very high regard in your interview process. So whether it's you involved in a simple audit, whether you're collecting data, it goes on your CV, and it's something that you can elaborate on in that interview. And if you interview well, you'll get a post. So I think people need to focus more on research, getting their primaries. The practical aspect of surgery will be taught to you during your time as a registrar, and you'll also rotate through ICU as a registrar as well. So don't become disheartened and think just because you don't have intermediates that you shouldn't apply for general surgery. May be different with other subspecs, but certainly for general surgery, having that primaries, some surgical exposure, and then obviously some research is held in very high regard.
Because the way other people have described it is research and publications are academic currency.
Correct.
Where you show that you've not only know how to do research, but you can generate research, can generate information that's going to affect patient outcomes and how you make decisions as a clinician. So it's great. So that's great advice. And then colorectal surgery in particular, what was it about that grabbed you? That's
bums, if you want to call it that. So which is.
Can you elaborate on that a little bit?
So colorectal surgery is colorectal surgeons in general are a weird bunch of surgeons. We have our own sense of humor.
Is it toilet humor?
Yeah, most of it. yeah, pretty much. So most people don't get it. But, I started my reg time in a colorectal unit.
Okay.
And really enjoyed the work that I was doing, especially the cancer work and looking at the amount of operable patients that we actually had.
Sure.
And it was great to see that. And then obviously getting that exposure in theatre with these low anterior resections and AP resections and some of the proctology work and colonoscopy and endoscopy. I really enjoyed that. And I just felt that there's so much of variation, so much of operable patients that you've got, that this is probably the area that I would go into, and saw fairly good outcomes with these patients.
That's always encouraging when you can
exactly.
see that you are actually making a difference.
Exactly, and that was a big defining factor for me. In a lot of subspecs, there are patients where you have a lot of inoperable patients, but generally in colorectal surgery, we have large volumes, and we're dealing with operable patients that have decent outcomes. Colorectal cancer, as you know, is something that's growing quite rapidly. Chadwick Boseman recently, Black Panther, demised, and there was an awareness created around that. And we're starting to see this younger group and younger population of people that are getting sporadic colorectal cancer. And it's interesting to see. We don't have an established screening program in this country, and it is a bit controversial. I'm sure they are working on it. But for the most part, it's something that's definitely growing in volume, and it's something that we're going to see a lot more of.
I think it's really useful when, whenever somebody who is a high-profile individual, whether they're an actor or a statesman or a sportsman, whenever somebody goes through their own health challenges, and it can be useful to help to educate the public and highlights things. I mean, for example, with Chadwick Boseman, now if you start to say to a 40-year-old black man that he needs to have a C-scope just as a screening, because there is somebody to relate to, he can now say, I can accept that now. Whereas somebody would, but I'm 40, I'm very young, doc, So it's great that colorectal cancer, from what you're describing, is something that can make a difference in patients' lives. I mean, I'm just thinking from a functional point of view, to be able to restore normal bowel functioning to somebody who's obstipated and, you're able to resect bowel and now they can go to the toilet by himself. You're restoring dignity to a patient. That must be really encouraging.
Yes. So it is good. Obviously, it's quite debilitating having a stoma, and there's certain stigmas around it. But, generally we have good stoma therapy care. We counsel our patients quite well. And, we've got a good colorectal unit, whether it's at Barra and Joburg Gen. Obviously, there are things that need to be ironed out because it's in state. But certainly, for the most part, we do a lot for our patients. We work as a unit. We have a multidisciplinary team meetings with these cancer patients. So it's great to see that. So I really enjoyed that aspect of surgery. I saw the outcomes and I loved it. So
would all general surgery registrars rotate through colorectal? Is that something that it's under the umbrella of general surgery? But what kind of rotations do you get to pick?
So generally, colorectal surgery forms a large portion of general surgery itself. Okay. So whether you're in a peripheral hospital rotating there, whether you're in a colorectal unit or a GIT unit, you will definitely have colorectal exposure. And it's something that I got a lot of during my reg time, and I enjoyed it, I loved it, and that's the path I chose to go on to. And obviously there's variations in the type of surgery you can do. So apart from you just doing open surgery, there's a lot of laparoscopic work that we do. Okay. And now obviously robotic surgery is something that seems to be growing. So I was recently in Switzerland at the St. Gallen European Colorectal Congress.
Oh, wow.
And got to play on the Da Vinci robot. And
sure.
It's something that's growing in our country. I mean, Critiscure now has a robot. And it's great to see that, there's quite a lot of robotic work that you can do in terms of colorectal surgery.
What's the advantage of doing robotic surgery? I know the pelvis is a very small space compared to, the rest of an open abdomen that, you're not just pulling things out and putting them back in. The pelvis is a very small space to work in. So that's one obvious advantage. What are some of the other pluses or gains from using robotic surgery?
Well, at the moment it is a bit controversial, but the most part in the cost-benefit ratio, if you can do something laparoscopically safely and you have a good outcome, then
sure.
Hey, it's fine. If you can do something open and have a good outcome, then it's fine. But generally we see the shortened morbidity period. So within that 30-day period, they have usually a shorter hospital stay and better outcomes from that, lower pulmonary complications and so forth. So it's great to see that robotic surgery is something that's growing. It's just the cost.
Okay.
To actually undergo something like this is obviously quite expensive. But the more we do, the more we'll know. And I think that needs to happen.
So this is still like cutting edge stuff with surgery.
Look, there are big trials that looked at the robot and non-inferiority trials as well, comparing, laparoscopic versus open surgery and where they provide some form of oncological benefit. But for me, the most part is that your patient gets out of the hospital as fast as possible.
Sure.
And it's not really the oncological. So there are a lot of people doing open surgery still, and it's safe to still do open surgery. It's safe to do laparoscopic, and it's safe to do robotic surgery. So certainly it's something that's going to be growing. You're going to see a lot more of it in the country, and it's great to see that. Look, at the moment in state, we don't really have that infrastructure.
Okay.
But it's growing because Critiscure, I think, has a robot now, and it's great to see that they are doing lots of robotic work. I think it's Critiscure or Stellenbosch.
So you've mentioned a number of techniques and a number of different surgeries that fall under the umbrella of colorectal. Do you have any procedures that you're particularly passionate about that when you see that on your theatre list, you're like, yes, I get to do this?
Colonoscopies.
Oh, really?
I have this weird... I don't know why. I really love doing colonoscopies.
Okay.
Look, a lot of medical GITs do colonoscopies.
Sure.
I love interventional colonoscopy. It's something I like. And obviously laparoscopic surgery. So I'm a big fan of art, but I'm not artistic.
You don't draw or paint?
Oh, hell no. I can't. So look,
you paint with a scalpel.
Yeah. So that's the thing. For me, a good, safe operation to me is art.
Okay.
Dissecting through a bloodless plane with a diathermy, going down, working in the pelvis, or taking out a colon, to me that truly is art.
Sure.
And I love it. And that scalpel or diathermy or whatever it is that you're using is an extension of your hand, and it's an extension of you, and it's your canvas. And having a safe outcome and looking at the smile on your patient's face 5 days later is priceless for me.
Fantastic, yeah. And are there any surgeries that you're like, this is actually, it's the drudgery of what you do? Are there any surgeries that you don't particularly enjoy? It could be, like you mentioned, outcomes. It could be because they don't particularly have good outcomes. It could be that they are long surgeries. It could be that they're very technical surgeries. What is it? Any surgery that you're like, these are my least favorite to do?
Look, we do get advanced cancers. We do get complex Crohn's disease patients.
Sure.
We do
inflammatory bowel disorder things.
Exactly.
Yeah.
We do get patients with a lot of pelvic floor dysfunction. we get a lot of patients that have had multiple surgeries, and obviously the redo surgery becomes quite difficult. Intestinal failure is something that is obviously growing in certain parts of the country. We have units.
Is it as simple as just adhesions and a tricky abdomen, or is there more to it than that?
It's just a difficult plane to work with at times. It can be difficult surgery to deal with, and especially with advanced cancer, locally advanced cancer. Multivisceral resections can also be quite difficult and challenging. So, these are things that do challenge us, but it's this challenge that we take on safely. And we would obviously prehabilitate our patients beforehand as much as possible. It's different with an emergency case, but definitely with the elective stuff, we try and optimize our patients as best as possible and try and get the safest possible outcome. So, we discuss this as a unit. We don't make unilateral decisions. It's fantastic because we work in a team, and having that team environment makes our outcome so much better.
Yeah. So, Doc, if I can ask you this, you've already given us a sense of what colorectal surgery is about. Do we have any misconceptions? Do you see people having myths or misconceptions about colorectal surgery, especially junior doctors or people who are just kind of dabbling in general surgery?
People don't like doing PRs. People don't like dealing with stool, and but the thing is that as much as it is part of the job, the work and the surgery itself is actually beautiful. And I encourage people to you can watch videos on YouTube. You can join me in theatre. You're welcome to join me on a colonoscopy list. And the surgery itself is fantastic.
Yeah.
Challenging, but fantastic.
So there's not actually that much poop involved.
There is. There is. Definitely there is. But I think that you just weigh your options out.
Yeah.
When you're choosing a specialty.
Poop versus vomit versus amniotic fluid versus urine. Different subspecs have their bodily fluids. It's not that bad, right?
No, exactly. And for me, we do work hard, don't get me wrong.
Sure.
We do acute care surgery as well in our hospital. So we'll be managing emergencies and so forth. But for the most part, I feel personally that I chose this path because it allowed me to have a better quality of life as well.
Oh, wow.
Which also was important for me, so I took that into consideration.
Yeah.
Because I like doing elective work. I like being in theatre. It's my peace time, So I love being there. I love being in the colonoscopy suite. I love doing upper endoscopies as well. And being a surgical gastroenterologist in its true nature. But, it's a difficult thing because people don't seem to understand that because you don't get that exposure. And I'm sure you have it as well. So,
look, as an intern, our tasks are mostly administrative, if I can put it that way, which is not to say that it's necessarily that everywhere, but it's still part of learning. We're still learning how to do basic things. We can't get thrown into the deep end too soon.
Yeah. No, 100%.
So, Dr. Naidoo, the landscape of colorectal as it stands or how it is at present, there's robotic surgery, there's laparoscopic surgery. What's the direction going forward? If you were to look into your crystal ball for colorectal surgery in 10, maybe 15 years' time, when our listeners will be specialising in colorectal surgery, what do you see the landscape holding?
So I'm very proud to be working at Wits. And I don't want to put colorectal just in one lump.
Okay.
I'd like to put surgery in general in that lump. And I say that because the one thing I'm very proud of and happy about that we do quite well here is the encouragement of gender equity and equality. And it's something we try as much as possible to focus on. When I finished my FCS exams, we had more female surgeons finishing than male surgeons. And these are mothers with kids.
Oh, wow.
And, we try as much as possible to support people that have families so that they don't get disheartened if they want to do surgery. And having that support system within which we still are working on, and transformation as well in itself, definitely. It's something that we're really trying as hard as possible to work on. It's something that moving forward, it seems to be changing, and it's a beautiful thing to see. And whether you're non-binary, whether you're male, you're female, whether you're a dad like yourself, with kids,
it's so comforting hearing you speak about people with kids,
Yeah.
And talk about like work-life balance as a surgeon, because
Yeah.
you don't immediately associate surgery with any kind of balance.
No, look, at the end of the day, you can't deny that no matter what you choose to do, whether it's within medicine or outside of medicine, to be successful, you have to work hard.
Sure.
That doesn't change.
Yeah.
You know, you don't have to be smart. I saw your old podcasts and I was watching some of them, and people like doctors have average IQs, and I 100% agree with that. You don't have to be the smartest person in the room, and we are not.
Yeah.
You know, we're constantly learning.
But you have to put the graft in. And reg time,
work in.
wherever you do reg training is hard.
Exactly. But there is support. And the other thing, obviously, is this mental health awareness. So it's okay if an intern comes to me and tells me I need a mental health day. Sure. I'm not okay. Sure. You know, and people still have the stigma of, you know, what's my consultant going to say? It's okay. We understand. We were there at one point, and what we want to do is make it better for the new generation coming in. Because at the end of the day, you know, I'm sure my prof would want me to be better than he or she is, and I would want you to be better than me at the point depending on whatever it is you want to choose to do. So I think we must have that support structure for the junior doctors and show encouragement to them. And I don't know if there's times where you've had, you know, like family responsibilities and you've had to leave, you know, like have we been supportive of you?
So actually last week, I mean, you bring it up, but last week I actually asked my consultant, can I have some permission to just dash out to my child's prize giving? You know, they have the prize givings at the end of the year. And he, without even flinching, was like, yeah, absolutely go. And I was like, oh, like I didn't know that I could even ask permission, you know? So I think it's one of those things where you just need to be given license to ask at least. You know, people are too afraid to ask, but if you don't ask, you won't receive.
So that fear stigma also, we're trying to establish this new culture. I mean, there's a lot of woke individuals, the new generation. You know, I'm a millennial, but the Gen Zs are a lot different.
Yes.
And it's fantastic, I think. And we need to breed a new culture of medicine. And it's great to have vibrant people around.
Yeah.
And we want to try and establish this culture where you can speak to anybody, whether it's the senior most prof or the junior most doctor.
Just to be a little bit more collegial and work together, you know?
You know, having that cooperation amongst colleagues is very important.
Yes.
So I think that even though we're working in a resource-constrained environment, it's stressful for everyone. The one thing that, you know, I can see changing slowly, but is changing, is that we tend to work as a team better.
Okay.
And it is improving.
So in 10 years' time, is that going to have reached some kind of utopian zenith where it's now we have no problems, or will there always be an element of...
I think there'll always be an element of problems, but the most important thing is that we have some way to deal with it. And we have some approach to dealing with these things. And we've had meetings before where we've had, you know, gender equality meetings, and we've had meetings where we've asked people, you know, what are your concerns? What can we change? What can we do better? You know, and it's something that is very important to me. And I like diversity. And the fantastic thing about working here is that there's this brilliant, diverse culture of this new generation and old. And everybody is trying as much as possible to work together. And this new culture is being bred into surgery. So that's why I just wouldn't want to talk about colorectal alone.
Sure, I understand.
But
so junior doctors coming into the fold can, you know, because what a culture is, a culture grows.
Yes.
So what you learn as a junior doctor is what you're going to propagate. So as an intern coming into that environment, if you learn well, if you absorb that, and then it doesn't matter whether you go into surgery or another department, you're only going to propagate that helpful collegial atmosphere where you encourage your colleagues, because coming out of med school, we're so competitive. You know, you rank yourself in class. Who's the distinction students? What position were you? Were you in the top 10? Were you in the top 5? And then you come to intern level and you just have to pull together as a team. And there will be some people who are stronger than others. That's a given. But it's encouraging to hear that there's the sense of whatever you're going through, you're not alone. And we need to work together, and we all have our strengths and weaknesses. That's really encouraging, I think.
Yeah, so it's definitely something I really like to focus on, and mentoring young interns, medical officers, or registrars is something that we're also focusing on. And it's great to see this new culture being bred in.
Yeah.
And I think for the most part, the main reason I'm speaking to you on this podcast is also to make sure that people don't get disheartened, wanting to do general surgery and saying, oh, they live and work so
Yes.
it's tough. I don't know how they do it.
Yes.
Why are they so uptight? And but things are changing and people are changing, and it's encouraging because we're self-reflecting. There's a lot more support available. So if you're burnt out, whether you're a consultant or an intern, there's a lot of support from each other, and everyone should take solace in that. And everyone that wants or is thinking about doing surgery should take comfort in knowing that there is support and you're not alone. So it's a fantastic thing.
Surgery can be stressful.
Yes.
So what do you do when it is stressful, and where do you draw strength from as a leader, as an academic, still students? So even this morning you said you were reading.
Yeah, at 5:30.
At 5:30 in the morning. Where do you draw encouragement from and strength from as a surgeon?
That's a bit of a difficult one. I suppose the biggest thing would probably be my mother. So, I think she finished her master's quite late on in her life. She was in her 40s, and it was great to see her because she would work non-stop. She had kids, and she looked after the two of us, and my dad was there and also worked quite hard. And it was great to have that exposure, and I suppose I emulated a lot of that, and so did my sister. So it's good to have that, but at the same time you need to have a balance. So you need to have some way of de-stressing. And people have hobbies. People do a lot of stuff after work.
Yeah.
And meeting up with friends, or doing whatever it is you choose to do. Focus on that. So work is 50%.
Yeah.
The other 50% is your private life. Or you can balance it and weigh it out as you feel necessary. And once you've done that, I think you've really mastered the art of finding that good balance. And people should not neglect their social life or private life because of their careers, because you'll be led down a very dark hole, and you shouldn't try to do that. And if you feel like you're going that way, again, there is support. A lot of people have made that mistake. I think that's the most important thing, is having a means of de-stressing and having a means of downtime. So when you go home, you do switch off, and I think that's very important.
Do you have any go-tos that's for you? Like some people would say video games or...
Yeah, I do. It's like when I'm on call and I'm waiting for something to happen, I'm usually playing Call of Duty. Or if I'm like waiting for something, I'm watching something on Netflix.
What is it about surgery that directs people to these most violent of video games?
No. It's just something I'll play online, or I'd play FIFA online or something. While waiting for a case to happen, I will have my downtime. I also take a breather just before I do operate and try to balance myself out throughout the day. And I think that's important, because you're going to be running up and down, working hard. And again, it doesn't matter what you do. Again, to be successful at it, you have to work hard.
And surgery in particular, it requires laser focus at some times, and you can't sustain that 24 hours a day. So it is important, like you say, to, when you have your concentration times, to balance it out with times where the mind is absent. The mind is just wandering, or the mind's relaxing. Relax your eyes, relax your hands. That's very encouraging to hear, Doc. And if people are interested in general surgery, or if they're interested in colorectal surgery in particular, what resources... do you have anything that you can suggest for them to start equipping themselves, start whetting their appetite for this kind of surgery?
So I think YouTube is a great platform to Google a lot of stuff. Or, those are the two platforms I would suggest you start at. And you can just Google it. And there's a lot of stuff that comes up. It's so easy to access information these days. And whether you're a student, I think UpToDate is a fantastic thing to have, whether it's on your phone, tablet, or your PC at home. It's a really good, resourceful place that you can find
I mean,
information.
medicine is in this unique place now where all
Yeah.
your textbooks are in your pocket and you can just access information.
No,
anytime.
100%. But in terms of surgical exposure, if you don't see a lot of it, I would encourage, people doing electives. So they're welcome to contact us. And if they want to come to theatre and have a look at, see what we're doing, then we're more than welcome to have students coming from outside. We've recently had someone that was a matric student that was interested in medicine that wanted to come and was shadowing us for the day.
Sure.
And it's good to show them how things work and how we do things. So yes, I think if you're interested in surgery and general surgery, it's not a bad thing to do an elective somewhere and get some exposure. And YouTube is a fantastic platform as well to actually learn quite a bit from.
Yeah.
Yeah.
Do you have any exciting stories or funny stories from your time in medicine so far?
Too many.
Do you care to share one or two without divulging patient information?
It's going to be a difficult one to do. But, you always have your run-ins with patients and you have your run-ins with a lot of things, but not in a bad way, in a very light. There will be those days where things will go a little bit haywire.
Okay.
But some people find solace in that chaos. So I don't think I can label it down to one sort of surgery that went bad or, like one experience that went sour. I suppose there's a lot of things. And, you will make mistakes along in your career. But the most important thing is, reflect back on it. There's support. You're going to feel bad about things when things go wrong. And again, there's support structures available for everyone. So just don't be so serious about things, I suppose. Yeah.
Awesome. Dr. Naidoo, you have in the pipeline wanting to do a podcast.
Yes.
And wanting to educate people about colorectal surgery. Would you care to take a bit of time just to tell us a little bit more about that idea? I mean, it's still obviously in its infancy. It's something that needs to percolate a little bit.
Yeah, hopefully you can give me some advice. So, on a Saturday morning, we usually run a presentation and we're inviting colorectal surgeons. Initially, it just started with the two fellows and it started to grow quite exponentially. And we've had people from Leeds come and present to us on pelvic exenterations, for example. And their experience, and we generally discuss patient-related things or simple topics and expand on it, and then have input from various colorectal surgeons in the province and from outside the province as well. And it's good to have that insight. In this scenario, what would you do? In this scenario, what would you do? And, people have varying opinions. And it's good to have opinions in your armamentarium because then you've got options. And if all those options are safe, then I don't see what the issue is. As much as we tend to practice evidence-based medicine, if your patient is walking out of the hospital 2 days later with the non-evidence-based medicine and you've done a safe operation based on your experience.
You're building more evidence for
Yes,
evidence-based medicine.
Exactly. So, you can, it depends on experience, and a lot of guys have experience. So it's great to start this, and it's growing. And part of the reason I went to St. Garland was to try and network, to invite people and collaborate with people from outside and from other countries to invite them to this platform. So it's something that's in its infancy. We'll be starting again in the second week of January. So I'll be presenting exactly what we did at the European Colorectal Congress in Switzerland. So
please provide us with the link so we can share that with others.
Students are welcome to join. Registrars are welcome to join. Medical officers that have some insight or some interest in it. It's usually quite a funny 1-hour presentation. So we're not there to ask you questions and rattle you about things. We just present. So
somebody need not worry about their level of understanding. A second-year student would be fine because they're not going to get grilled on the spot. So.
No, it is advanced stuff, but at the same time, it's all relative because something that you may think is advanced may not necessarily be advanced. And again, medicine in itself is something we put a lot of emphasis on, and it's actually a very simple field to work in.
Sure.
There's just a lot of work to get through.
So when you are going to these conferences in Europe and overseas, do you find that your level of skill as a surgeon, or your level of training, I should say, is comparable? Or our surgeons that we're developing and training in Africa, would we be able to hold our heads up high with our peers overseas?
Yes, definitely. So I initially went, so this was the first time I went, and I thought that what we were doing is quite rudimentary, but it turns out that we are doing quite a lot of advanced stuff in South Africa.
Oh, wow.
We're seeing quite a lot of advanced pathology, and it's something I think we need to work on in terms of research. So you're saying going forward in colorectal, having a database and pulling out more research so we can present at these conferences, and what we're seeing is vital. And it's something that we need to look forward to in the future. But definitely we're on par with First World, in my opinion. And I think having that exposure and then interacting with the profs from Amsterdam and from Basingstoke in the UK, or one of the Turkish big Turkish hospitals, interacting with these people was fantastic, because we got to share experiences, and it's not that we're doing anything rudimentary here. We're actually doing quite advanced stuff.
Awesome.
So I think they'll be sending some of their registrars from Belgium or the Netherlands, and they would like to start sending their fellows as well to do electives here. So it's good. We may actually start an exchange program, something to look forward to in the future.
Yeah.
And I think the future for colorectal surgery in South Africa is bright.
Awesome.
Yeah.
So if you could now speak to our audience of medical students and junior doctors, if there's anything that you'd like to communicate to young people, young medical professionals in the country, anything that you think maybe would be motivational or encouraging, if we need some correction in an area, a lesson that you've learned that you want us to remember out of this interview.
Try not to take life so seriously.
Okay.
Try not to take things so seriously. Have a level head about things and step back when you're stressed out. It's okay to be anxious, but when you're not stressed, you're not anxious. And if you have a little bit of confidence on a ward round, even if you don't know anything, just ask. Because having that anxiety disables you from actually learning.
Yes.
And I think it's important that young people understand that, especially students being on around. We're there to teach. It's a fantastic platform to teach from. And especially for registrars writing their exams, I think it's important to understand that teaching students is a very good way of reinforcing your knowledge bases.
Yes.
So whatever it is you've learned, go and find a student or an intern and teach it to them.
Wow.
It's something that I found, and I was taught by one of my profs. So, and it seems to work.
Yeah, they share the knowledge.
Quite well.
Yeah.
Well, I don't know. I did it with you when we were in ACS together. So, and you were my student. So, and it did work for me. So, that's something I would encourage people to do. And again, just try not to take things so seriously. Just have a good balanced life, and when you go home, switch off.
Yeah, that's awesome, man. Thank you so much for your advice and for your inputs.
Thank you, Simon.
It's been an absolute pleasure to have you on the podcast. You've brought a fantastic perspective about colorectal surgery and general surgery in general. But it's been a wonderful pleasure to have you on the podcast. Thank you very much for your time, Dr. Nishlin.
Thank you very much for having me, Simon. Take care.
Well, that's it for this episode of the Dr. Coffee podcast. I hope you enjoyed it and feel motivated, encouraged, and inspired. If you have feedback on what you thought of this episode, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram and YouTube with the username @drcoffeeza. If you've got anything else in your mind, such as a request for additional topics or further information on how to engage with our guests, please get in touch. We'd love to hear from you. Consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy it. Thank you so much for your support.